Good morning, everybody. Welcome. We're so excited to see you all here today. I hope you've enjoyed your stay so far here in the Washington, D.C. area. And for everybody online, welcome. We're so glad to have you here today with us. We have a packed program. It's really interesting. When I first began planning this in about January, February, I sent a message out to our doctors and said, hey, anybody interested in doing something live this year? And I tell you what, we have 17 presenters, so let's give it up for our presenters today. They were all willing to jump in. We are going to have some that are going to be virtual, but we have a lot of them in person that you'll be able to mingle and interact with as we go through the day or the days. So we're really super excited about that. So I do want to start off with just a few housekeeping things for the people that are in the room. On your tables, you'll see that you have these cute little frames. There's also some markers on there. You can put your name on it. You can do whatever you want with it so that people at your table know who you are. So enjoy that. And of course, we have lots of good treats and stuff for you to munch on during the day. We will have a nice lunch a little bit later out in the lobby. We're also going to have our wonderful dinner this evening with a keynote speaker that we'll pick up out in the lobby, but we'll bring in here so we can listen to our keynote speaker. And we have all these wonderful tables out here. I saw you guys already mingling out there with the pharmas. There is so many great things happening in the HypoPARA world. So go out there on your breaks. Before we start this evening, they'll be open as well for you guys to be able to talk. We have Ashley Kirk here they've done the clinical trials from Physicians East. They've done them for TransCon, Calcilytics, Amulet, so they're a wealth of knowledge for anybody that's interested in that. So there's a few of those housekeeping things. Again, some of our presenters are going to be virtual, so for you guys in the room, you'll pay attention to the screen here, and they'll come up on the screen. Other than our first presentation, we will have opportunity for Q&A afterwards so that we'll run around and let you guys ask some questions to the doctors. And then tomorrow, we're going to have a panel with 4 doctors that you can ask questions that you would want to ask. So we're really excited about that. Let's see. So anybody online, if you're having any trouble getting online, please look at our website. You'll be able to see the information there. If not, Michelle will be monitoring her email this morning. It's mrays@hypopara.org, and you'll be able to get connected that way. But no matter what, again, everything's recorded, so you'll be able to see these things for forever. Also, for people at the table, you'll see a little card on there. It says Voices of HypoPARA. This is super important. We'd really like to get as many people as we can to be able to sign up and do the survey for Voices of HypoPARA. We want to hear what your experience is like as a patient. So please take some time. It'll be open for a couple of weeks, but please take some time. For you guys online, it is on the website, so you can take a look at that as well. All right, so doing an event like this takes a lot of people to pull it together, and there's a special group of people that I really want to recognize before we get started, and I turn it over to Bob. Early on, we couldn't decide if we were going to do hybrid, if we're going to do in-person, if we're going to do what we were going to do. And we were able to find these fantastic production crew, which you guys see has done an amazing setup here, right? So we really want to thank John Dudley and his crew for such an amazing job. Yep, very good. And then we also have Calcilytics is here with us. So anybody from Calcilytics in here, they're back there. Yeah, welcome to them. Ascendus was also a sponsor. They're back there. Thank you so much. We also have Amulet in the house, and they help sponsor this event as well. MBX is here. We'll be able to hear from them for the first time this year, so welcome. And Takeda was also a sponsor this year, so we want to recognize them for their sponsorship. We also have, like I said, Physicians East. Ashley Kirk is here to be able to help talk about clinical trials. So we're really excited about what today is going to bring over the next couple of days for you. So we talked about being the change, right? And what does that mean? So as we go through the next 2 days, I want you to think about yourself, but also think about the greater good in the community. When you think about where we were to where we are today in development, it's pretty darn amazing, right? So I really want you to think about that. I want you to think about how can you be a part of the change? How can you be the change? And again, we'll talk about that a little bit more. But before we move on, I did want to introduce to you our president, Mr. Bob Sanders, and he wants to share a few words before we start.
Thanks, Patty, and gosh, I can't believe it's been 4 years since the last time we all met in person, 2019. So I'll just wrote a few things down. So anyways, yeah, welcome to the 2023 International Hypoparathyroidism Conference. Seeing these new and familiar faces just swells my heart with joy. You know, being able to connect is what this is all about. Again, like Patty, I want to thank our sponsors, the ones that make all this possible. I want to thank Finn for helping us get the word out on the social media campaign and really grow in the community. It's amazing to see how many new members we see every day. I see new members pop up on the website and connect through the website as well through social media. Right? These are all people that I'm not going to say they're lost, but you know now they're found. I also want to thank the HPA Medical Advisory Board and the speakers here today, tomorrow, for their continued commitment to the HPA mission. Again, my name's Bob Sanders. I serve as president for the Hypoparathyroidism Association. And we drive change by, sorry, I lost my place. Anyways, I just want to acknowledge another individual person, which is Patty Keating, for putting this event together. She's been working tirelessly since, like she said, February, putting this together. And I'm honored to be here with the rest of the board. Michelle Reyes for all the hard work she puts into it, and Deb Murphy, and many of you known her for a very, very long time. Loretta out running the registration. Unfortunately, Barry Vapnik is not here. She's been running the social media campaign. We cannot do this without the support of the board and everyone else. So real quick, Patty asked me to kind of share a few things. You know, and since 1995, HPA has been committed to raising awareness for the hypoparathyroidism community and has advocated for better treatment options for patients and their families. This all started when my father, James Sanders, enrolled in the early PTH 1 through 34 trials at the NIH in the 90s. Sorry if I get emotional. After doctors realized that this was a genetic condition in our family, they decided to enroll the rest of us children. This put us at the Children's Inn, and I don't know if anyone's familiar with the Children's Inn at the NIH, but we're literally living in a community. We have our own separate rooms, our own suites, but we share community sites, you know, so we share the living rooms, the kitchen, the dining rooms, and because of that, we all started forming these bonds with all these families, with children with other rare diseases around the world. And if you knew my father, he always put the needs of others above his own. He was always in the service of God and in his fellow men. You know, throughout the years, we remained in contact with many of those families, and some of them who are no longer with us. I truly believe that he was inspired to organize the Hypoparathyroidism Association based on our experiences at the inn. He did this with Julie Hunsaker, who's no longer here. She passed away in 2020 from pancreatic cancer. And then Lorraine Bolton and my mom. The four of them started this organization from the ground up. And it all started by just a little monthly newsletter connecting all the patients that were in that original trial and staying in contact with them. And building on those relationships, he brought together a so-called medical advisory board, connecting even more patients and more doctors together, and advocated for change every day, always putting the needs of this community at the forefront. HPA was instrumental in getting the first PTH replacement therapy to market with Natpara, and today we continue to work with industry leaders, researchers, doctors, and regulators to bring the next therapy to market. As many of you know, hypoparathyroidism is a rare endocrine disorder. affecting the lives of approximately 1 out of every 2,000 people. The impact of hypoparathyroidism on those living with the condition cannot be overstated. It has led to significant physical, emotional, financial challenges for patients and their families. However, despite the impact of the condition, there is still a considerable awareness or lack of awareness and understanding of this disorder. At this year's conference, we've chosen the theme, Be the Change, like my father, to highlight the critical role that we, including our sponsors, organizers, and attendees here, online and in person, play a role in driving positive change for those impacted by hypoparathyroidism. Being the change means taking action to create a better future. It means using our skills, resources, and expertise to drive positive change for those in need. It means being a champion for those who cannot be championed for themselves. Our sponsors work tirelessly to bring forth new and exciting treatment options, some of which you will learn about over the next 2 days. Caregivers sacrifice themselves for those who may or may not be able to care for themselves. Patients who participate in clinical trials and studies that get the industry and the researchers the necessary information to move the ball forward. Patients and caregivers are telling their stories for the world to hear, stories that let members know they are not alone in this fight and give hope for a better tomorrow. Those same stories are the driving force that affects change in policy and treatment standards today. So please, never stop telling those stories. They're important. Our doctors take the time to learn about hypoparathyroidism, and educate patients, to educate their patients. They also take that information they learn and educate other fellow doctors, industry leaders, and researchers worldwide. Together, we all play a critical role in improving the lives of everybody affected by hypoparathyroidism, and we are excited for the future. Over the next few days, let us think about how to be the change. For those impacted by hypoparathyroidism, we will be hearing from doctors and experts, industry leaders, and some of them who are patients themselves. Topics covered will be clinical trials, clinical updates and opportunities, current and future treatment options, and medical devices, and mental health. We'll then close the conference to discuss the importance of advocacy, education, research, and offer practical tips on getting involved in this vital work. We will continue to share our stories, successes, challenges, to come together as a community to drive positive change for those impacted by hypoparathyroidism. So let us explore how we could all be the change for those impacted by hypoparathyroidism. Together with our sponsors, our generous sponsors, support, and our organizers, hard work, we could create a better future for all. And I want to thank all of you for taking the time out and attending this conference with us today, and explore the theme of being the change. Thanks.
Thank you, Bob, for that wonderful message. All right, so we're going to move on to our first presenter. And again, for you guys in the room, it is going to direct your attention over here. Dr. Shoback, Dr. Dolores Shoback, is from UCSF Health in San Francisco, California. She's actually going to be doing 2 presentations for us. Today, she wanted to just kind of give an overview because she said there's so much going on in the hypopara world. So many different things that are happening with the task force that she wanted to give us an overview to really kick off the conference. So enjoy.
Good morning, ladies and gentlemen. My name is Dolores Shoback, and I'm an endocrinologist from the University of California, San Francisco, and the San Francisco VA Medical Center. And I'm really delighted to be able to speak to you this morning. I so wish that I were there at your conference. I know this is always a great conference, and I really, really enjoy meeting you and talking with you and working together on this very important topic. So my charge this morning is to talk to you about work that's gone on over the last almost 3 years to put together the second international workshop on hypoparathyroidism. I'm going to share with you over the next 30 minutes or so some of the highlights from 4 task force reports and the guidelines that came out just this past year from the work of this important international workshop. So before I speak, I want to tell you that I do have a couple of disclosures. I serve as an investigator on the Pathway trial, and I hope to be an investigator on the Calypso trial with the new PTHRP analog, and have been a member of the steering committee for the Paradigm registry. So this second international workshop, as I said, worked over about a 2.5 year period. It was led by Dr. Aliyah Khan, who'll be speaking to you today, and also by Dr. John Bilezikian, who many of you know. And this workshop put together 4 task forces on this disease. The first was the one on epidemiology and financial burden. The second was on etiology and pathophysiology. The third was on genetics and diagnosis, and the fourth was on management of the condition. And then finally, there's also an important paper on guidelines led by Dr. Khan and her co-authors. Why is this so important, and why did I ask to speak to you about this? Well, I think it's so important for us who work in this field and for you who are contributing knowledge every day to this field, and it's very, very important, is that this task force put out several very strong scientific papers that were peer-reviewed, that really covered the condition of hypoparathyroidism in its totality, I think. And I think this is going to help all of us as we work together and go forward. Because when you publish strong papers, the message is out there and it's respected and it's strong. It gives update in a field, and this really matters because it focuses the attention of people on a given disorder so that people can work on it, think about it, and then treat their patients hopefully in a more up-to-date and efficient way. And then just by having new papers that come out, your healthcare providers may get to see a new paper on your condition and learn more. So I think for all of these reasons, these are important papers. And this makes the disease, if you will, more visible to both the public and to the medical profession. And maybe a science writer will come and write a paper, an article about this, and again, raise disease visibility. And then for you, new papers come out and you might share those with your providers. So these are amazing resources, these papers. So the first one, as I said, put out by the Task Force on Epidemiology and Financial Burden, was led by Dr. Bjorn Stotir, as well as Dr. Clark, who's the senior author here, and some of the other international members of this task force. Why is this paper important? Well, it covers both the prevalence of the disease, the incidence, the mortality, the healthcare burden of having hypoparathyroidism, and some of the complications of hypopara. And then, importantly, because funding agencies like the NIH, they look at papers like this, and this paper gives us a research agenda. So where can we do work that will help this field? There's a very important table. I won't go into it in detail because we're going to cover so many different areas this morning in a short time, but it really goes through all the different cohorts across the world that have over 500 patients in them, and tells us what are some of the predictors, if you will, for the development of permanent hypoparathyroidism around the world. So it's establishing an incidence, if you will, of the disease, and that's very, very important. This is a really important table that's in that paper. It's on kidney complications. And I know this table has a lot of information in it, and the numbers and the words are in very small print. But I will just tell you a few things about how we look at a table like this, okay? So first of all, let's start over here on your right, where I've put some definitions in here. So kidney complications, another word for kidney is renal, okay? And so CKD is an abbreviation we use, and it stands for chronic kidney disease. And chronic kidney disease has 5 different stages. Stage 1, your kidneys are perfect, okay, and progressing all the way across to stage 5, where you're preparing for dialysis or on dialysis. So it's a spectrum. It's the different stages of chronic kidney disease, and each one is a progression along the way. Nephrolithiasis, that word means kidney stones, okay? So we all know what those are, but that's the technical word. Nephrocalcinosis, again, means calcium. Calcinosis is calcium, and nephro is kidney. So calcium deposits in the kidney. We want to try to avoid that because that can damage kidney function. And then finally, hypercalciuria, high levels of calcium in the urine. So these are like 4 parameters that we look at as physicians, for example, to kind of know what's happening with your kidneys. Okay, so one of the very important tables in this paper from the first task force is summarizing across the world all this important data on kidney complications. So let me explain it even a little bit more. So if we start over here on your left, where I've put this yellow arrow, we're first looking at single center studies, okay? And here's one out of Boston. And so what this table tells us is this study out of Boston, patients in it, 41% had chronic kidney disease, 30% had kidney stones by imaging, a quarter of them had high urinary calcium. So this is stacking up all the data from all these different countries, 6 different countries, where they've looked at kidney complications in hypopara. Then if we take a look down here, we're looking at population studies. And again, you can see 5 or 6 different countries. And let's just take the first study, which came out of Denmark. You can see the N means almost 700 patients with hypopara were included. And then they give us this statistic called the hazard ratio. And that means the risk of having something, the hazard of having something. It's a statistical point. But what it's telling us in this Danish study is that the risk of having chronic kidney disease if you have hypopara compared to the normal population of Denmark is about 3 times that rate, okay? And the same with kidney stones. The rate of kidney stones here is about 4 times the rate versus the general population. And so, we're not going to go into every number that's in this table. That would take way too much time, and you're not interested. But what I'm trying to say is that in this one little table, you've got the world experience summarized with the kidney complications of hypoparathyroidism. And so that's very valuable. A healthcare provider can sit down, look carefully at this table, and learn so much information about the kidney in hypopara. So this paper from Task Force 1 has other really key information, and I think all of us are interested in the different topics that are covered here. So what they summarize with respect to mortality is that the results are mixed. We don't really know that hypopara across the world increases mortality. The studies don't agree. The healthcare burden, in contrast, is real. Hospitalizations, ER visits, almost 80% of patients experience those. Interference with daily life, 50%. Household activities not performed, almost everybody. And then a change in employment in about 20% of people. So this is really, it seems so simple, doesn't it? But it's really useful information because it tells us really what it's like to live with hypopara. The kidney data we've just gone over a minute ago. The bone information that's summarized here basically tell us that if you make sophisticated measurements of bone structure and bone mass, we can find changes. But fractures are likely not increased, again, if we look across all the studies in the world. Cardiovascular complications, most of the studies, but not all, will say that hypopara doesn't raise the risk, but not all are in agreement. In terms of cataract risk, it is greater, but the duration of the hypopara and the age when it was diagnosed are critically important. And they appear at a younger age and so forth, okay? Basal ganglia calcifications, yes, that's part of the picture. Infections, 1 or 2 studies say it might be increased. Cancers don't seem to be increased. That's great news. That's good news. Neuropsych issues, yes, greater rate of depression and bipolar disease and anxiety. So all of this kind of information is summarized in that one task force report. So again, very important, very useful. Okay, so that second task force, we're going to take them one by one. So this second task force looked at etiology and pathophysiology. So etiology means the cause, And pathophysiology means how does it happen? How does it come about? Tell us how it comes about. So what I like about this particular paper is that we were able to include 4 really top endocrine surgeons in this task force. And one of the first things they proposed, and it's so straightforward and simple, but so important, they said, let's make a consistent definition of what chronic hypopara is. And that was proposed, and it was adopted by the entire workshop and became part of the guidelines. And so that definition is a low serum calcium and a low PTH persisting 12 months after surgery. So that's really, really important, a basic definition that we all agree on, and we do. Table 1 talks about non-surgical causes of hypopara. Table 2 in this paper talks about the views of surgeons. Again, we had a strong surgical voice here. The views of surgeons on different stages of low blood calcium that they see and how they're recommending to their colleagues to treat it. Table 3 looks at some of the symptoms that the surgeon should, use to recognize hypopara, and risk factors for the disease in their patients. So what I like about this paper is that we have a very strong group of endocrine surgeons speaking directly to their colleagues. And I won't read all of this to you, but this is a direct quote from this paper where they are saying, here is our definition, here's the blood calcium to look for after surgery, even if there are no symptoms, okay? And they remind you that it's usually transient. And they talk about the monitoring that should occur in the first 6 hours after surgery. So I think that's critically important because, again, in one place, surgeons talking to other surgeons about how to take care of people in the immediate post-op period. And they're also saying treatment needs to be instituted if people have symptoms of hypopara, and what that treatment should be, calcium salts and activated vitamin D, given to them prior to discharge. This paper also talks quite a bit about some innovations that are being done by our surgical colleagues to reduce the risk of this happening in other people. One of those things is doing what's called autotransplantation. In other words, if a parathyroid gland is removed inadvertently during an operation, to get it back into that patient pronto. Okay, and so they're encouraging that, which makes perfect sense, but it's important that that be emphasized. They're also developing ways and testing ways to identify the glands in real time, like right there in the OR, and protecting them and preserving them and not taking them out of the neck. Okay, and they're also looking at techniques where you can inject a dye into the vein and then see whether the tissue in the neck is actually a parathyroid gland and whether it's viable or not. And then they're using fluorescent properties of tissues like the parathyroid to try to preserve those glands in the neck. So lots of surgical innovations coming because they're listening to the fact that this is an important complication that we're all trying to prevent. And another thing about this paper is that it covers some of the very interesting work on bone involvement in hypoparathyroidism done by Dr. Rubin, whom you're going to hear from, and Dr. Dempster, Dr. Belazikian, and all of those investigators from Columbia University. But so it talks quite a bit about the bone. And as you know, we often do DEXA scanning to check for bone mass and look for osteoporosis. And this is just a reminder to you that often the bone density in hypopara is higher than normal. It's not often in the osteoporosis range. But this work from Dr. Rubin and her colleagues show that the structure of that bone, we call it the microarchitecture, the fine detail of it, is different from people who have normal parathyroid hormone levels. And the levels of bone markers, we call them, bone turnover markers, those are often low, signifying the fact that normal levels of parathyroid hormone, those are critically important for maintaining the level of bone turnover and bone integrity. And then this is just, I always am impressed with this picture, but this is a picture of a CT scan at the microscopic level of a bone biopsy from a control patient over here on your right, and then a patient with hypoparathyroidism. And you can see structurally this bone is very dense from the patient with hypopara and much more open and biochemically active in the control patient. So this is just telling you that at the structural level, the bone looks different. And then there's a nice discussion of the causes of non-surgical hypopara in this patient, in this paper. So again, I think a very, very interesting and important paper on the topic. So Task Force 3, we're moving right along here, hopefully, talks about genetics and diagnosis. And I think you can recognize the authors here, Dr. Monstad, Dr. Roscoe, Dr. Brandy, Dr. Gaffney, and so forth. So many contributors who often speak at the Hypopara Association meetings contributed to this task force report. So again, stepping back for a moment and just talking about what is in this paper and why is it important. Well, there are several tables, and the first one talks about what's the probability of developing hypopara after a surgery. So it summarizes, again, statistics from all over the world, and that's very powerful and very important because then surgeons can look and compare their success or lack of success with what's going on. How is the field evolving? How are things getting better? This second table is an amazing resource. It summarizes all the different genetic causes of hypoparathyroidism. To me, it's the most complete, the most useful table with the most current information that I've ever seen on this topic. So very valuable. And I said here for all endocrinologists to have a look at. Because if you are seeing patients with non-surgical hypopara, and every time I've come to this meeting, I've met with several of you, we need a resource to go to look up this information because it doesn't come in the office every single day, and we need a good place, a good resource. And this is an excellent resource for any of you to look at who are trying to understand why you have non-surgical hypopara. And then this table 3 gives us some detailed information on calcium sensing receptor antibodies. This is more important for researchers, but the reason I tell you about it is that I want to assure you that we are looking for biomarkers in different forms of this disease, and this is potentially one of those biomarkers. So this paper also has a bunch of really valuable recommendations. The first is when you do obtain that parathyroid hormone level after a total thyroidectomy, what we can do with that level is predict who will not develop permanent hypopara. So that can be very reassuring for the patient. So say 6 to 12 hours after a total thyroidectomy, if you have a parathyroid hormone level that's above 10 picograms, for example, okay, the chance of getting permanent hypopara, it's very, 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 very low, okay? So often you will not need any kind of long-term treatment. But if the values are less than 10 picograms per mil, 12 to 24 hours after surgery, you do have a significant chance. It's less than 50%, but it's real, of having long-term hypopara. Why is this important? You might say, gee, that's such a fine point. But doctors like guidance, and they like it spelled out, and they like it based on evidence. And as I've put over here, this is a strong recommendation because they've got good quality evidence. There's a lot of studies that support this simple concept of that number, that PTH value. So that's a very important recommendation. As simple as it sounds, it's very valuable to have out there. Who do they recommend to have genetic testing? That was another important recommendation of this task force. So they said it should be done in people who have a positive family history or have other features of different forms of hypopara, like that table I mentioned to you, or who are younger than 40 years old. So if any of you haven't had genetic testing and you have non-surgical, these are the recommendations now from the most up-to-date task force report on genetic testing. They recommend air gene testing if there are any features of autoimmune hypopara. And then they give us a definition for what has been called idiopathic hypopara. And sometimes when I talk to patients who are non-surgical, they say, well, I was told I have idiopathic. I don't know what that really means. So when we do all of the testing that we can do, up to the limits of what we can do, if the testing is all negative, then we can call that situation idiopathic. And then again, this task force agreed with the surgeon's definition, which is 12 months of hypocalcemia and low PTH levels after surgery. And again, healthcare providers, doctors, we like the guidance spelled out, evidence-based, make it simple, make it straightforward so that we can do what we need to do. So that's why all this is so, I think, very, very important for the field. The final task force paper was led by Dr. Kahn, and you can see many authors on this paper. And this is about how to manage hypoparathyroidism. So really, really important, because that comes into play every single day of our lives with this condition. So this paper focuses on different strategies and advice for healthcare providers. The first table looks at the different complications and the symptoms, and they cover everything. They cover all kinds of hypopara, post-surgical, non-surgical, and even in children, and put together the complications and symptoms. Again, the one-stop shop where you can find all this information. Then the second table, which is terrific and is big and very, very helpful, puts together all the different studies that have been published on parathyroid hormone therapy and hypopara. It lists every single one and how many patients were in it and so on and so forth. So again, if your doctor is wanting to read one paper on the management of hypopara, this is that paper, okay? Because it's just got everything very nicely put together. And then this final table here, table 3, looks at the findings where they compared parathyroid hormone therapy and conventional therapy in this disease. And the comparisons are on quality of life, depression, reduction in calcium and calcitriol treatment, adverse events, discontinuations, and so forth. So it's a side-by-side comparison of the two different types of therapy. So a really, really valuable, really important paper on management. Again, the one-stop shop. Finally, turning now to this 5th paper, which was basically the guidelines. It's a summary statement for evaluating and managing hypoparathyroidism, and it also put forward the guidelines from this second international workshop. So you can see that Dr. Kahn led this, Dr. Bilezikian, Dr. Clark, who many of you know, and Dr. Monstad and Dr. Guyette. Okay, so guidelines, those are very, very important. Because what a guideline does is it takes all the evidence in a field, from the beginning of time almost, and it benchmarks that evidence against the standards that we use to judge, treatment efficacy and safety and recommendations in all other areas of medicine, like comparing it to the management of heart attacks and hypertension and so forth. So standing up to those benchmarks, those high standards for evidence, for example, is a tough thing to do, okay? And we don't always have the highest level of evidence in a condition like hypopara. But what we did in these guidelines was to include what's considered expert opinion when we don't have all of that high level or large amount of evidence from randomized trials. So guidelines do that benchmarking, and that's really, really important. This paper included authors from all over the world, which is really important because we need to work together and we need to, bring everybody into the fold in terms of giving advice and managing people with this condition. And this paper has 7 really important recommendations, and we'll go over them in a moment. These were the strongest, and so they made they separated out those 7. And then they have, and I think those are very valuable ones as well, what they call ungraded recommendations, because the evidence wasn't quite there for these others, but they're still important because we have to make decisions on how to manage those different aspects of hypopara every single day. So we've got a lot of good advice in this guideline paper. So what are those 7, what I call main or key recommendations? The first is something very basic, and I've mentioned it before. How should we diagnose hypoparathyroidism? They couldn't grade this recommendation, but it's critically important, right? That's the first step. Are we all making the diagnosis correctly? So we need a low ionized calcium or a low total albumin adjusted calcium. Okay, so a calcium and albumin need to be done. And then the person needs to have an undetectable, a low, or an inappropriately normal PTH measured twice, at least 2 weeks apart. So that's, again, a basic definition. It sounds so simple, but we need to agree so that we're talking about the same thing. So number 1 recommendation is, how are we going to agree on the diagnosis? The second important recommendation is, how can we reduce the risk? How can we mitigate the risk of this happening to other people? So the recommendation is, if a parathyroid gland is removed inadvertently, you don't want it to be removed, okay, reimplant that gland right away, okay, and avoid removing things that aren't supposed to come out of the surgical field, okay? The third recommendation, and this one was graded because there was enough evidence, and I've already mentioned some of it to you already, get that PTH, get that calcium 12 to 24 hours after the big thyroid operation. And I mentioned to you already the cutoff of 10 picograms per mil. If that level is below that, you have a good chance of having problems initially with calcium and then potentially down the road, and this may progress. If it's over 10, the risk of having chronic post-surgical hypopara is much lower. So this is a very important recommendation that went straight into the guidelines. Then they looked at, and I didn't put this table in there, but when you take a look at this paper, you'll see it, some of the signs and symptoms by surveying articles and endocrinologists around the world, some of the most common symptoms and signs of hypopara, and that was graded as well. Now, their 5th recommendation relates to monitoring people with chronic hypopara. What's optimal? Okay, and you can see over here, all of these were not very high quality evidence, just didn't have a lot of data. But at any rate, expert opinion tells us that for new patients, measuring kidney function by the creatinine, measuring the estimated glomerular filtration rate, again, part of kidney function, the blood calcium level, the magnesium, the phosphorus, the albumin. That needs to be measured, obviously, in a new diagnosis, and then every 3 to 12 months for patients who are stable and are in clinical follow-up. The vitamin D at the outset, and then every 6 to 12 months, making sure that that 25 hydroxy vitamin D level is in a good range, at least, in my own personal opinion, at least 30. Okay, and then a 24-hour urine for creatinine and calcium at the beginning, and then every 6 to 24 months, depending on the situation with the patient. In the text, it says we should do a baseline assessment for kidney stones and kidney calcifications, and you can do that by renal ultrasound or kidney ultrasound or kidney CT scanning. So that should be done at baseline. And then if you're making a change, if you're making a change in the calcium supplements or the calcitriol supplements or the PTH for that matter, then you want to monitor the serum calcium within either a couple of days of that change or, within a week or so. So these are just some very basic monitoring recommendations for patients with this diagnosis. So how should patients with hypopara be managed? And this was also a graded recommendation, but still on the low quality side because we have few randomized trials that guide us here, but we're able to grade this recommendation. So the first line therapy is treatment with conventional therapy, which is calcium supplements and calcitriol. And they made a comment on this recommendation that if conventional therapy isn't working or is thought to be unsatisfactory, then you consider the use of parathyroid hormone. And this is very valuable because we don't have a tremendous number of trials here, but we know that if people are not doing well, this is a place where you would consider parathyroid hormone replacement. And that's going to be important when we're dealing with insurance coverage of the new parathyroid hormone preparations that likely are to come to the clinic. And then they made 9 more specific recommendations about all kinds of different medication, like our supplementation, like magnesium supplements, vitamin D, looking at the phosphorus. All of them are important. I'm not going to go into each one here today, but I just tell you that this is a very thorough paper on management of hypopara and guidance to the clinician who's trying to manage this. The 7th important recommendation that I'm going to tell you about is a series of recommendations, if you will, about pregnancy and lactation. And first time, this is so important. This is the first time really pregnancy and lactation is front, right, and center in a set of guidelines about hypopara. And that's a very, very good thing. So in women with hypopara who become pregnant, they propose that we try to have a serum calcium in the mid to low normal range throughout the pregnancy. This is really, really important. You want really good control of the calcium during pregnancy. And you want to see that the phosphorus, the magnesium, and the vitamin D are also normal during pregnancy. Then it's recommended that calcium be measured every 3 to 4 weeks during pregnancy and during nursing. And you may also more carefully monitor for any symptoms of low blood calcium, that's hypocalcemia, or high blood calcium, hypercalcemia. Finally, doctors taking care of these women should work closely with the obstetrician and the pediatrician to make sure also that the baby is carefully watched for a low blood calcium or a high blood calcium. And then finally, we are not approved to use thiazide diuretics or parathyroid hormone or parathyroid hormone analogs during pregnancy. So what we've reviewed over the last 30 or 40 minutes are 5 really important papers from this international workshop that took place during the pandemic. As I described to you, this workshop established 4 task forces in different areas and took a really refreshed view, a modern view, if you will, of the disease. There were working groups of healthcare professionals from all over the world. There were patient advocates involved, and there were members of the Hypopara Association. You can see the picture of Deb Murphy up there smiling over here, and Bob Sanders, who were authors and participants in the work of this task force. And what I find so very important is that this task force, this effort, brought together a whole group of international investigators, including surgeons, really important, and including junior investigators, so we can get our younger colleagues interested in working in this field. And one thing I haven't emphasized, but I will now, is to tell you that the most respected academic group that works on evidence-based medicine that basically developed the field of evidence-based medicine. Dr. Gordon Guyette and his team were involved from the beginning all the way through to make sure that the guidelines that were developed were high quality, were evidence-based, and of the best possible caliber. And that's so very important because they're will be respected by everyone. And then importantly, these guidelines were endorsed by 65 different endocrine societies from around the world. And I've just included a picture of Dr. Guyette over here and our friend and colleague, Dr. Aliyah Khan, who led this effort. And with that, I will stop. Thank you so much for your attention, and wish I could be there to answer your questions directly. But I had wanted to present these papers from a very high-level view so that you knew that this was really valuable information that's now out there for all of our physicians and our healthcare providers, and for us as and for you as patients to read and learn from. So thank you again, and enjoy this wonderful meeting.
All right, thank you. Thank you to Dr. Shoback, right?